So they asked me, what is this thing about CT-guided PCI, Carl? I said, listen, here in Saudi, we normally do angiogram, we do IVUS, we do FFR, but this CT thing, it's not really well known. So can you teach us CT-guided PCI in 10 minutes? I said, yes, of course. This is very easy. So if you know nothing about CT for PCI, you will learn everything you need to know in the next 10 minutes. So that's basically my role today. And this is, of course, the title of the talk, Everything You Need to Know About CT to Guide PCI. And the 4 names that you need to remember that are relevant of CT for PCI are these on the slide. 3D MIP, axials, MPRs, and cross-sections. There is nothing outside this slide that you should know. Why? Because here is everything that we need to know to assess the case complexity, select the guiding catheter, understand how to prepare the lesion, and know where to land with the stent. And I will explain each of these, how they actually work. Let's start with the first one, which is very easy. For us interventional cardiologists, it's extremely easy to look at this picture. This is a reconstruction that is done fully automatic by any scanners in the market. 0 post-processing. The problem is that the radiologists or the imagers, they don't know that this is useful for us, so they don't put it anywhere in the packs. But this is extremely useful, as I'm going to explain you why. Of course, we know where's the right, where the left is, where the left main is, but you can quickly understand how many vessels are diseased, what is the degree of tortuosity, if there is a CTO, etc. And this basically takes 10 seconds before you go in the lab. And it's completely different to go in a case that is in the right side of the slide. This is a 10-minute PCI of the right coronary, and that one is a 1 hour, 2 hour PCI with plaque modification of the LAD. So basically, to understand this, it takes 20 seconds. You just need to look at this picture. And of course, you have a number of different scenarios, but you clearly understand here the degree of complexity that will basically change one. This is a case for radial. I have to go femoral. This is 7 French, maybe 8 French, depends what you're going to do. And of course, everything is based on the degree of calcification. So those are the MIPs. The second point is the axials. The axial is very simple. Basically, this is used by the radiologist to make the diagnosis. We will not use this to make the diagnosis, but we will use this to know which guiding we need to use. In this slide, you will see, there's a bit delay, that the normal position of the right coronary is at 10, between 10 and 11, and the normal position of the left coronary is at 5, and everything that deviates from this position requires a different guiding. So this is normal position of the right coronary, normal position of the left coronary. This is how they look. And I'm going to show you different scenarios. So you take the axials, you scroll 10 more seconds or 20 seconds, and you will see different takeoff. If you have a normal takeoff, this is what you get in the angio. Basically, a Judkins will be enough. Of course, if you're going to do a more complex intervention, you might decide to do something different, but the cannulation will be simple. This is an anterior takeoff. It's not a coronary abnormality. This is common. It's about, the prevalence is about 30%. And if you have this takeoff, you need to use an Amplatzer left. Otherwise, you will have support to go, especially if you're going to do an intervention in a severely calcified tortuous vessel. And this is a coronary anomaly. This is basically the right coronary taking off from the left cusp. And you will see here that you will need an IL and perhaps an IL1 or 2 to actually reach that coronary. So when you start using CTs to guide your procedure, basically you don't change anymore the guiding because you don't have support. That's over. So you basically use less guiding and you have to do less change of catheters. Now, the MPRs is the third reconstruction that are useful because they show you the disease in this plane and you can understand the disease severity, the length of disease, the plaque distribution, and the plaque composition. This is how they look. Pretty easy to recognize. I advise you to look at this in movement because you see the coronary in 360 degrees and this is very, very easy to see. Now, why are these important? Look at this case. Normal, severe lesion in the proximal LAD, you see here the MPRs, and you will see that there is a fully lipidic lesion, you understand the composition, but what you have not seen is that the plaque go much further than the stenosis. And there is a calcified nodule in the proximal part of the LAD that if you are not using intravascular imaging systematically, you will be landing in that place and you'll perhaps have a complication related to the landing zone. Good. And just to finalize the cross-sectional aspect. The cross-sectional are very easy for us because it resembles what we are used to see in IVUS and OCT, and you can understand the arc of calcium, the plaque burden, and the plaque vulnerability. I will explain how to look at those. This is basically the types of plaque that you can see in CT, lipidic, fibrosis, and calcified, and you can identify those, of course, based on the visual aspect or looking at the Hounsfield units, you will understand what is the plaque composition. And the lipidic plaques, you can classify them further. I will not go into the details, but all these features has been associated with plaque vulnerability, and we're going to have a specific talk about vulnerable plaque tomorrow, where I'm going to describe this in more detail. Now, what I want to focus with you in the next few minutes is the most important characteristics of CT, which is the fact that it's very easy to assess calcium. And this is how we see calcium in the cross-sectional view, and you can understand that how calcium can be circumferential or non-circumferential, and this takes us to a next level where CT is actually helping us understanding if plaque modification is required and how to do plaque modification. So this is not the future, this is what we're doing today, and this is the different reconstructions that you can get from calcium for CT. Of course, you can look at morphology, as I already showed you, but we can start looking at calcium in 3D. And for the first time, we can have a measurement of how hard is the calcium by looking at the density. I will show you how that works. This is basically what we are getting from the reconstructions, and you're going to see this for the live case that's going to happen afterwards, where we're able to see the calcium in 3D. So we're not only seeing the calcium in the cross-sectional, but now you have an idea of where in the coronary wall is the calcium located, how does it extend in the vessel, and in this case you have a calcified ring of calcium just before the take of that diagonal, and this of course makes the assessment of calcium extremely intuitive. This calcium, as I mentioned to you before, can be further stratified by looking not only at the arc of calcium, but from this arc of calcium we can extract the Hounsfield units of the calcium. Now the Hounsfield units of the calcium are shown in the top part of that slide, and you will see that all those calcium look the same, but they're not the same. There are hard calcium and there is soft calcium. So I'm telling you that with CT, we can now stratify the calcium not only by semicircumferential, circumferential, thick or long, but also on the density that basically is a predictor of the response to therapy. I will explain that further, and I'll show you a couple of cases where we have now calcium of, we call this calcium 1K, calcium 2K, which are basically predicting the response to both plaque modification in terms of presence of fractures and, of course, extent expansion. We're going to go to that later. Now, everything that I have mentioned is basically becoming very easy. So in the next 5 years, you will not need to learn how to look at these pictures because everything now has become three-dimensional and very intuitive to look at. So any interventional cardiologist without any training in CT can look at this picture and understand that the white is calcium, that there is some calcium in the roof of the left main, some calcium in the inferior wall of the LAD. And look at what I'm saying, calcium in the inferior wall of the LAD, that's extremely easy to see. And then what is coming now, where we're testing, is that this can be put inside the cath lab. And these pictures are synchronized with the C-arm. So every time that you move the C-arm, you are seeing, of course, the angio on the left and the plaque in 3D on the right. And this adds a different level to any procedure because for the first time we can see the plaque live. So imagine that for every single case you have a complete depiction of the disease in terms of the plaque composition, plaque extension, plaque morphology, and next to it, the physiological component that I did not have the time to look at that. This is everything that you can get from CT relevant to PCI, and this we call it the P4 approach, which is basically the title of the trial, where we are randomizing patients to being treated following everything that I have been mentioning in the last 10 minutes. We call that CT-guided PCI, and we're comparing that with IVUS-guided PCI. And I'm happy to say that we're about to close recruitment. So we have almost 800 patients. We'll finish recruitment early next year. So in a couple of years, the field will completely change with a new modality basically able to help us guide PCI. To summarize, and I think perhaps we'll be ready to go to the case, I think that CT has evolved in a way that is not only anymore a diagnostic tool. CT is a planning tool for PCI. This is being tested in the P4 trial, where we're going to generate the necessary evidence to use this in clinical practice. And we believe if the trial is positive, this will become the standard of care. Thank you very much for your attention.
Thank you, Dr. Collet, for this